And we're going to go ahead and just dive right into it and get started. So we were lucky enough to have Dr. Kim with us last time, facilitating the panel, and she's going to give us a little bit of a background about what we spoke about before, and then I'll have the panelists introduce themselves, and then we'll get right onto it.
Thank you so much, Alicia. So I'm Kim Sue. My pronouns are she, her. I'm the medical director at National Harm Reduction Coalition and an assistant professor of medicine at Yale. Yeah, we've been really excited. This is something that a lot of people, I've talked to a lot of people around the country about this. And I was just saying that Chris Maraf and I were talking about doing these webinars maybe 6 months or, 6 months ago at least. And so we're really happy to finally be able to put this on. The first part of the series, which is recorded, and maybe we could also drop the link in the chat or at some point, and we can send them out in the resources, really covered, things to know from sort of what xylazine is, which I think we'll talk a little bit more about today, clinical responses to xylazine, how to respond to an overdose with suspected xylazine involvement. And we had some researchers talk about their research showing the prevalence of xylazine around the country. And really today, we hope to focus on strategies that people on the ground, people who use drugs, foregrounding their stories and experiences, ways that we can support them, and how harm reductions on the ground are responding. Obviously, we know that people who use drugs are the experts, and we'd like to really focus their experiences, what they have them tell us what they need, what policies we need to do, what we need funding for. And so we hope to do that with you all in the next hour and a half. And we are so delighted to have this wonderful group of people from around the country. So I think we're going to start off with Chris Maraf.
Thanks.
Yes.
Thank you very much. So share screen here. Right?
Yeah. Real quick while you do that, Chris, folks,
Yeah.
we will have a Q&A portion at the end. If you want to ask a question, if you could put it in the Q&A function, that'll help us keep track of it a lot better. So feel free to drop questions that you have throughout the presentation in there.
Okay.
All yours, Chris.
So my name is Chris Maraf. I guess I wear many hats. I started covering marginalized communities about 25 years ago as a freelance journalist. And I guess 6 years ago, immersed myself into the Kensington overdose problem, which was beginning to spike with the introduction of fentanyl into the drug supply, the heroin supply. I now am a co-host of Narcotica podcast, some of you might be familiar with, and I'm launching Narco Media, which you'll learn more about in the coming weeks, I suspect. But I would start by saying that as Rafi pointed out in the first segment, xylazine isn't exactly a new drug of abuse. It's been a component in some way, shape, or form. I'm sorry, in Philadelphia. A little bit about me. This is me hanging out with harm reductionists when I first introduced myself into the Kensington scene and began basically following them around and learning a lot from them. These people saved a lot of lives, and they taught me how to do the same. But because we have a large Puerto Rican population here, xylazine, or it used to be called sleep cut back in the day, now Trancto was somewhat around. I mean, there was small amounts of xylazine in drugs or in heroin in Philadelphia, probably going back at least a decade, if not more. A lot of that changed as the composition of the drug market in Philadelphia, or the heroin market in Philadelphia specifically, changed. So now we have, I work with a drug testing program that tested, I think, up to 400 samples so far. And I think we have the highest percentage of xylazine in our dope of any city. It's upwards of 98%. It's almost impossible to get a bag without tranq in it. 3 years ago, when I really first started hearing, about tranq from people who use drugs that I used, the sources that I spoke to, it was possible to avoid it. Some people liked it for their nighttime shot. It kept them asleep longer. We all know that fentanyl has a shorter half-life. It doesn't keep you as long as heroin. It doesn't hold you as long as heroin. So the addition of tranq helped people sleep through the night. That some people found it beneficial for that. But as the drug market, the composition of the drug market changed, which I'll explain to you in a minute, the percentage of xylazine in the bags has just exploded. I mean, we've tested bags that have almost all xylazine with just a touch of fentanyl, and so let's see if I can go to this next slide. So this is a place called El Campamento, which was in 2017 was closed down by the city, but it was, for all intents and purposes, an outdoor drug user and drug dealer led safe or somewhat safe injection site. Out of the 1,200 people that died in 2017 in Philadelphia of drug overdoses, according to the medical examiner, only 17 of them passed here. I watched many reversals here. There was always naloxone on site. That was shut down in 2017 and created sort of a diaspora. This is the segment of Philadelphia that was the old entrenched heroin market. This was run by Puerto Ricans and Dominicans above them. Generally, suppliers were Dominicans, street dealers were Puerto Rican, and there were rules, there was structure, there were caseworkers, there were middle managers, there was a hierarchy that maintained itself from generation to generation. I also incorporated the first strip testing there, I believe, in Philadelphia around that same time when we started testing for fentanyl, using fentanyl strips. So the composition in the neighborhood looks something like this. Over here is the area in detail I was just showing you. And then you've got a main thoroughfare going through here. And over here had traditionally been an Irish white neighborhood. It's now sort of a no man's land that's up for grabs. And you see a lot of freelance dealers out there that are not connected to any of the multi-generational sets over here.
Hey, Chris.
Yeah.
Sorry to interrupt. Can we put it in presentation mode? I think folks are having trouble seeing the smaller details.
Oh, yeah. Do you know how I do that?
The
if you-
slideshow on the upper right.
Yeah.
This thing.
Next to the share button, if you click slideshow, up on the right top, that you see that yellow button right there.
Oh.
At the top of your presentation screen.
Oh, okay. I see the new share.
No,
slide.
I'm sorry. So if you look at your Xylazine presentation,
Okay.
and you're in the Google window, you see that little Google camera icon that's in
I
the
do.
right. Okay, you're gonna click slideshow right next to it, the word slide.
Oh, I don't see it. Okay, I gotta move it over, or maybe move this over. Ah, I see it now. I'm bad. I'm sorry about that.
No worries.
It's hidden behind this thing. Let me bring that down. There we go. Share.
No, if you click slideshow, it should go into presentation mode.
It's weird. It's not. I can maybe make
It's
this.
okay. You know what? We're
bigger.
actually going to send out for folks who are having difficulty seeing. We can actually also just send out a copy of the slides as well for you to review afterwards.
Yeah, I'm not sure why that's not working. Maybe because we already started or something. Okay. Well, I will zoom in a little bit on this then, if you like. It might help. No, I'm zooming out. That's very strange. Okay, it's zooming out. All right, I want to get back to where I was.
Yeah, it's all right. Go ahead. Sorry about that.
So, the long story short, when that camp was closed down, it created a heavy police presence over here in the sort of established hierarchical heroin markets, and created a void in the marketplace that was filled by freelance dealers that were buying fentanyl in small amounts and popping up for maybe a week, 2 weeks on a corner selling it. And that's when we saw the overdose, the overdoses spike by threefold in Philadelphia. There is a high bar of entry to the heroin market. You need to have connections. You need to have a lot of money. The fentanyl market is not quite the same. So I will move on from that because that's just a little background about what's going on in the, the area that we're talking about here in Philadelphia. This is the same area of detail that shows you, this is where the camp was. This is Kensington Avenue down here, which separates the two sort of sides. This is where Prevention Point is, for those that you don't know. And all around here are drug markets. These were established drug markets. These have been here since I was using in the 90s. So I mean, and some of them are like, probably the same owners. Some of them are not. But over here we have an entire freelance, like just corner after corner that just pops up. And that's where we really started seeing some of the worst cases of xylazine. Over here, you can still buy a bag for $10, and it's going to be mostly heroin, a little bit of fentanyl, and an even littler amount of xylazine. Over here, you're going to get fentanyl and xylazine. That's it. I mean, it's $5. It's half the price. But there are users, especially old time Latino users that are, they definitely want heroin, and they will pay for it. So that's an interesting market dichotomy that sort of like this grew out of this forced diaspora of people from one side to the other. So now I started noticing probably around 2018 things like this. This guy I went over to and was ready to administer Narcan, and I realized he was sleeping. He was passed out. He was not overdosing. He was not blue. He was breathing, but he was completely unconscious. I believe I got him up briefly, but then he started walking towards the street, fell back down, and I thought he was probably better off where he was. That's a concern with the xylazine, especially people are sort of walking, it's almost like a sleepwalk sometimes. And I've seen people wander in traffic, had to walk people out of traffic. Here's another example of somebody that's just done, this is what the pharmacological effect of tranq looks like, as opposed to anyone that's ever used heroin is going to know, you're going to get energy, you can go to work. These people cannot do that no longer with the influx of tranquilizer. So with the influx of freelance drug dealers, there were several experimental failures throughout the course of the past 3 years. One was synthetic cannabinoids that were introduced as an adulterant into several different brands of dope, because there was a symbiotic relationship between the two that sort of mimicked a benzodiazepine, heroin high, where they would put people on the nod. People generally didn't like tranq for a while. Now they can't avoid it. It's everywhere. So I started seeing this around 2018, and had heard, of course, of sleep cut, and started hearing about people talking about the dry mouth and some of the less the more innocuous side effects that come with tranq use. And then I started finding these. This was found by a source, actually. This was found by me. This is Manit, which many of you will recognize as a very popular heroin cut. And these are all bottles of xylazine. And that's when I realized that we had a lot more of a problem than I thought we did. I mean, I think I did the calculations here based on the weight per, I did, and I think we had like 30,000 doses or something between all of this. And I spoke to, the only information I think I got from one street dealer who probably didn't know a lot, but claimed to have seen her boss turn this into cut, was that they take fentanyl, they dump this on it, put it in the microwave, and zap it, and then probably mix it up and throw it in bags. So the dosage is going to vary. It's relatively easy to get. It's not scheduled, obviously, as of now. It's a veterinary drug, but that may change in the future. So we were there already. So in 2019, I wrote this article that seems to have gotten a lot of play. I think it put a lot of people on. It put trank dope onto the radar as something that was coming around the bend in larger amounts. I got that's when I began getting contacted by UNC, people from UNC. Dr. Su, you reached out to me, like, and people were starting to recognize that Philadelphia was becoming a center for this. So where am I going with this? So from there, like, I don't pretend to be an expert in the pharmacology or the toxicology of this. From what I can tell, and from watching people use it, it actually puts people to sleep. It sedates them. So it's easily distinguishable from an overdose. Because unless somebody is overdosing and on trank, in which case naloxone is definitely your first line of defense. But I've seen people that were amped up on meth, snort a bag of dope and go to sleep, like snoring. But that's not the biggest problem. I mean, like I said, some of the big problems are people doing it on the street and then walking into traffic. There's only a correlation. I'm not saying it's a causation, but I think last year I had the highest number on record of people falling in front of subway trains in Philadelphia. You can make what you want of it, but a lot of people use on the trains. Then came this. For the first time, I started seeing abscesses that look nothing like abscesses. And these are, I wish I could make these bigger, because these are necrotic. It's nothing like the abscesses that you see on cocaine users that miss, or heroin users that miss. These are black necrotic lesions that sort of stay there. They really don't heal. They have, I believe it's because of the vasoconstricting the components of the xylazine, that whatever kind of bacteria might get in there, it doesn't get flushed with white blood cells in much the same way that, like, a normal wound would, and it just festers there, and it turns black. It's really necrotic. I know a guy that used to cut, he would what's the word, there's a word for when you cut out the dead skin, but he would cut out the dead skin himself. A lot of people are doing that. And for the first time ever since I've been covering Kensington, there's now antibiotics for sale on the black market, which is really striking for a first world country, so to speak. And most of these people have medical coverage because under Medicaid. And that's part of a whole other talk about why people don't seek medical treatment. People who use drugs don't seek medical treatment. Here's a small formation. This is an early onset one that you can see. Like, this is not a missed shot. This is a shot in the vein, and it's already opening up, turning black, and pretty soon we'll have a black scab over it. We had a little trouble with convincing doctors here that that's what this was from. And I think we're pretty much universally in agreement now that this is from the xylazine. Some doctors thought it might be because of the increased meth use that's now happening in Philadelphia. We had an influx of meth. It's all over the place. I mean, it's cheap. But I've no IV meth users that don't have these kinds of marks on them, and almost anyone that shoots dope now does. I've heard stories of people that snort dope that get it. I don't know if that's a function of you hear lots of anecdotes when you do my job. You hear lots of people who know somebody who this happened to, so unless I see something firsthand, I can't say that's for sure. But I have heard from doctors that these kinds of lesions can show up in non-injection sites, that they can travel. People have gotten scratched on an area of their body completely independent of their drug use, and have gotten this type of wound there. So this is the drug checking. Yeah, this is the one I wish I could open up for you. This is our drug, just a small portion of our drug checking program that shows you a good sampling of what Philadelphia's heroin is composed of. And this is fentanyl cut with xylazine, containing a small amount of parafluorofentanyl. Fentanyl cut with xylazine, small amount of lidocaine and caffeine. Fentanyl cut with xylazine, fentanyl cut with xylazine, fentanyl cut with xylazine, trace amounts of lidocaine and tramadol. It's an interesting aside. We're seeing some tramadol like pretty regularly showing up in our bags, and I'm not really sure why that is, and our lab is still trying to figure that out. But as you can see, every single one of those is fentanyl and xylazine. And unfortunately, I cut off the one underneath it, which actually was just heroin, which you see very, very infrequently. So I think that the lesson here is we need to expand sample testing so we can get ahead of some of these issues before it's too late, and before we approach like a cluster of something happening that we don't know what it is. And that happened in 2008 with the synthetic cannabinoid outbreak. They were a couple of sets were cutting the dope with it, and people were getting Narcan because the obvious belief was that there was an overdose happening. And then when they were left with nothing but this tripping like synth can high, they were getting agitated, etc. So it was really counter, and it was like it was counteractive almost to Narcan, some of the people, because they weren't overdosing, they were tripping from synth cans. We need to expand drug checking programs that test in real time or as close to real time as possible. I know that there are some municipalities that are doing that, and Philadelphia is happy to help anybody that would like to know how to do that. But again, there's restrictions. I'm pretty loose. I've had people mail stuff from Chicago. Like I'm under the impression that as a journalist doing the job I do, that it would be very easy to prove that I'm not in any way like skirting the law for some nefarious purpose. But there are risks involved in this, obviously. But drug checking is really important, and learning more about this drug by talking to veterinary professionals and finding out what kinds of impact it's had on animals, which, as I understand, it doesn't have much at all. But to date, we don't really have anything to counteract it. People just go to sleep and wake up and then lose time. Maybe somebody else can speak to the potentiating factors between xylazine and fentanyl. It almost seems like it's two different things. They're being sedated and they're also getting their high, and I think that there is a belief that it might extend the high a little bit. And fentanyl has really changed the game because people can't go to work anymore like they used to with fentanyl or with a heroin, where you could grab a bag in the morning and maybe it would hold you to the night, cop on the way home. Fentanyl has led to a clustering on the streets because every 4 hours, there needs to be another fix. And
Hey, Chris.
yeah.
Sorry, we're just going to go ahead and be a
Yep.
little mindful of time. I know you have such a
Yep.
wealth of knowledge in the background breaking the story. For panelists, for participants, we're definitely going to send out a copy of the slides as well. Feel free to follow Chris on Twitter and stay in contact with him as well. We're going to go ahead and pass it over to Louise, who's going to talk a little bit about her experience in North Carolina. Thanks so much, Chris.
Yep, you're welcome.
Great. Can you guys see me? I'm having trouble with my screen on my end, so I don't know if you can see me.
I can see you.
I can. You can see me?
Yep.
Okay, great. And you can hear me good? All right. So I didn't bring any slides today. I sent Dr. Sue some pictures. I really appreciate, and I really
put Louise's pictures up. Thank you.
Real quickly, just before we do that, wanted to give a content warning. I know we did it in
Yes.
the chat, but verbally, there are going to be pictures of wounds, necrosis, etc. We just want to make sure folks are mindful so they can click out if they need.
Yeah, this is a rough conversation for sure. And I really appreciate being part of it. Um, and that is my arm right there, about a year ago. And it doesn't look loads, but it's been 2 years now since I was exposed to xylazine, and my arms still really look rough. So this is a serious conversation for me. And drug checking saved my life. So our drug checking service that we were putting up at the same time as this was happening actually ended up, I'm certain, saving my life. There's a lot we don't know, but there's a lot you just heard that's absolutely true. Some that I'm going to push back on. And that's just my personal experience. So I'm sharing one experience in time. I'm from Greensboro, North Carolina. That's a city of about 300,000 people. We don't have great organized crime here. So the thing about organized crime is it's organized, right? Here, pretty much anybody can become a dealer if you've got a little bit of money and access. And that presents a lot of opportunity for a lot of people that don't know what they're doing to get involved. So what happened to me is I was moving from methadone to buprenorphine because, and this was pre-pandemic, I wanted to travel. I wanted to travel and I wasn't able to travel the way I wanted to. And so everybody was like, you need to move to buprenorphine. And so I made an attempt to move to buprenorphine that was really rough. I didn't know about the Burmese method. I didn't have good access to doctors that were helping me do it well. And what happens, I went into a crazy precipitated withdrawal and sort of swore buprenorphine off after a while, after this happened a few times. When I tried to get back into the clinic, they were really ugly to me and had said that I had been using the program and they didn't want me back. So this had me out of the clinic, and this was the first time I was out of the clinic in years. And then that was really devastating. So I was sort of slow about trying to find another clinic. Lots of clinics wouldn't take me because I have, I also take alprazolam and other drugs that they are not thrilled with. So it was very hard for me to find a clinic to get back into. And I was using street drugs until I could figure this out. Because I had just come from a methadone clinic, and really always I've had a very high sort of threshold for how much opiate I can use, which is not great on the pocketbook, right? That's expensive. And what I found is exactly what was shared, is that there was something about the opiate I was buying that I thought was fentanyl, and I thought it was some analog of fentanyl that maybe they hadn't discovered yet or didn't know, that had a very long half-life, right? I was able to stay well through work. It felt a lot like methadone to me, except there was this initial sort of, you're going to fall asleep and take a nap for like 20 minutes, and then you're going to be good for the rest of the day. And you're going to be able to work and you're going to be fine. Now, other people I was around when they would try to use it, I mean, it would just knock them out. It would just pass them out and they were useless. I mean, I'm talking about like putty in your hands. You could pick them up and they just fall right down. Really scary. I mean, people just sort of passed out all over the place looking to be overdosed until you got right up on them and then they would wake. Awake 1 minute and asleep in the other. I could certainly see how crossing the street could be dangerous. Leaving the house was dangerous for folks that I saw in it. And so really I just thought, well, I have this high tolerance and this works for me right now. And as time went on, and I guess I need to say that I don't just use heroin. So mostly I've been a person that uses speedballs, so that I've used cocaine and heroin together. And so this drug sort of mimicked that in some ways, even though it was, you know, a tranquilizer of sorts. Whatever was going on with this mixture really, really was quite nice. So I have to say, this is the hard part about this drug. While I never want to use it again, and while I think it's truly dangerous, I liked it. And so that's one of those things you have to remember, that it was ticking boxes for me. I was able to go to work. I was able to take care of myself. It was cheaper. You know, there was all these ways in which it was helping me. And so I made, you know, allowance to use it more and more. When the pandemic came and really set in, everything was much more expensive. The prices of everything went up. And so this seemed like an even better option. I finally got into a clinic, but I was not able to go above 40 milligrams because of my alprazolam use. Which leads me to say that, you know, I need to say that, like, in the United States, and certainly in North Carolina, methadone is the safe supply, right? And we need to do better about getting people into methadone and not having all of these regulations, because what was continuing this was my inability. You know, I was in fact using quite a bit against, I mean, I was trying to figure out how to manage my life with a poison street supply, because I couldn't get the clinics to operate the way I needed them to, and I couldn't get them to meet me where I was. And that's a real problem. You know, this went on, and then I started noticing really bad, you know, abscesses on my arms. I've never had abscesses. I've never had problems with, you know, I've had track marks. I've had that. I've never had anything like what you see there. And what you see in that picture is after a year of not injecting there, not taking Xylazine, and having lots of cleaning. I mean, that's you know, and they still are, they're getting to a point where they're almost they're almost not as thick, but or they're not as indented so much, but really really tragic. And I was starting to feel really bad. So something was happening that I couldn't put my finger on. And this was the drop of my hemoglobin. And we don't have any good evidence about this now, but I am certain, and they found some old articles about impalas, where impalas lost hemoglobin. And so we are actually buying hemoglobin detectors here so we can see what's happening with people. I believe the two are related. They've not been able to find any other reason for this loss of, you know, when I went to the emergency room with Nab and Roxanne, I went with a hemoglobin of 2. And I think you're supposed to transfuse at 7. And I think you're supposed to be walking around with a hemoglobin of like 14 or 12, something like that. So 2 was not good. And, you know, by that time I had lost my memory. I was feeling like I couldn't breathe. Really tragic. And so I remember I looked at Don one day. We got a new sort of batch, and I was desperate. My girlfriend was carrying me into the clinic by this time, and they weren't really doing anything. And I said, there is something wrong with what I'm using. Because he had learned how to use the FTIR machine. He had gotten it up and running. I said, would you please go test this? And so he went and tested it and called me on the phone and said, don't do any more of that. And that's when we found out it was Xylazine and with fentanyl and some other stuff, you know, at different times. But and we started looking that up, and we started finding out what the side effects were, and we started ringing the alarm bells. And unfortunately, I don't think the alarm bells have rung as much as I would like them to. I believe it's more than just wounds. I believe that there's serious, I believe people have serious reasons that they want to use it. We have people coming in. I believe it's absolutely dangerous to be that sedated. You know, I've found people in cars. I've found people like just laying down on the ground, like you saw in the pictures, really just unresponsive almost. I have reversed an overdose that had xylazine in it, but it also had fentanyl. So fentanyl is what it was reversing. But it's truly frightening and truly, truly scary. And the wounds really make it even harder to go to the doctor because they're embarrassing and terrifying and just another stigmatizing reason that drug users have to not use medical services. I wrote an article when I still was absolutely, I don't know how Filter was able to make it into words that made sense. I wrote it directly after I got out of the hospital. I nearly, it had to do with hiding my wounds. And it was a Filter article, and thank you, Will, for helping me put those words and making those words make sense, because at that time I could not even I mean, really, my memory had been affected. Everything had been affected so badly by this that it took, transfusions and months of rest for me to repair any, so that I could really get back to work and do what I love. Drug testing and checking are, it's necessary in today's environment, where we have all of the different contaminants and things people don't know. We need a system for alerts. And I feel the same. You're welcome to send to Greensboro any sample you have, and we will send you the results of the sample. And we'll send them to Chapel Hill and get confirmatory results. Nab and his team have been excellent. So that's really, I mean, I just wanted to share like a personal sort of somebody you guys might know, somebody that you have heard from in the past that has experienced this and really just been spun around by it, and almost killed by it, to see how important and because I just don't think we're getting how important it is. I like, there's some like push around it, but I don't hear the level of concern that I would like to. So I really appreciate being invited here today, and for everybody listening to my personal account of xylazine. So thanks.
Awesome.
Thank
Thank you
you.
so much, Louise. We really appreciate it. You sharing your story and calling to attention how important this is. We're going to go ahead and keep on moving forward. The next person that we have up is Adam. So Adam, if you want to go ahead and just, feel free to put your presentation on if you want to introduce yourself really quickly, and then the floor is yours for the next 15.
Awesome. Thank you. I'm going to put my presentation on in just a couple minutes. That only comes in at the end. Thank you, first of all, for having me on here, Harm Reduction Coalition, and for creating this platform for us all to speak on. Thank you, Chris and Louie, for sharing that information. A lot of what I'm going to speak about today definitely touches on it. I can recall countless situations where, had I been armed with the proper information, I could have made an actual difference, a positive impact, or just less of a negative one. So thank you very much again for providing this platform for us to speak on. I am the co-founder and director of operations of Savage Sisters Recovery. Our mission is to attack addiction ferociously with radical love through connection. We accomplish our mission via a three-pronged approach. We offer the recovery community access to trauma-informed transitional homes. We serve those in active use via street-based outreach. We serve the public by offering Narcan and substance use education. These combined strategies reduce the stigma around substance misuse, reduce overdose deaths, reduce the spread of harmful disease, empower those in recovery from substance use, and provide basic materials and compassion for those still using. Today, I'm going to provide information discussing how Savage Sisters has been responding to xylazine in the local drug supply, which is better known as tranquilizer or tranq. Tranq is put into the drug supply by suppliers to give it longer legs, which has already been touched on by Chris. Savage Sisters has been seeing the effects of tranq in the dope supply since we began our outreach efforts, but much more significantly in recent times. We host outreach every Tuesday night at McPherson Square, which is a centralized location for those experiencing active use and homelessness in Kensington. There we serve at least 75 people with food, Narcan, fentanyl test strips, syringe kits, smoking kits, safe sex kits, hygiene kits, PPE equipment, and more. We also lead a cleanup crew, and we offer folks transportation to treatment and information to get into it. In addition to our weekly events, we host a large event every third Saturday of the month, doing all the same stuff we do on Tuesdays, but we add in wound care as well as a bunch of other materials, and there we serve at least 250 people. I'm going to touch more on that wound care in just a minute. Tranq has been reported to have been in the drug supply in Philadelphia since 2006, but in recent times, as Chris mentioned earlier, it's been reported to be present in at least 90% of the dope supply in Philly. In 2020, the Substance Use Prevention and Harm Reduction Division In the Philadelphia Department of Public Health began a partnership with the nonprofit sector of the Center for Forensic Science Research and Education to test drugs and monitor the street supply in the city of Philadelphia. To date, over 400 samples have been tested. Throughout the course of this testing, more than 260 of the collected samples were suspected dope samples. More than 90% of these samples came back with xylazine as the primary cutting agent. However, there's been a recent increase in certain side effects as well, which we've noticed during our outreach events. We keep our eyes peeled for overdoses where naloxone doesn't work on its own or immediately, and the wounds which you've just seen and heard about, which are abrasions, open wounds, lesions, and more. And we're seeing these all over people's bodies who have been using tranq, the presence of which they know or do not know about. Regarding the issue of open wounds, lesions, and sores on people's bodies that have used xylazine, considering that 90% of the dope supply is laced with tranq, most folks using in Philly are experiencing the symptoms, one of which is those severe wounds. Whether people are snorting, injecting, or smoking, they're developing these wounds. You do not have to shoot. The injection site where people inject is not where the wounds are developing. It's just anywhere a wound develops. If tranq is in your system, it is susceptible to really bizarre open wounds. Our only response is to offer wound care, which I mentioned we've been providing during our outreaches. So during the monthly events, we're joined by several nurses that lead a wound care station. The number of folks that have wounds that don't seek treatment for them is surprisingly immense, as has been mentioned earlier, for a plethora of reasons, which is why our wound care team has recently been in incredibly high demand. Our wound care team deals with the issues they can, cleaning wounds, dressing them, but in situations where infections or the risk of limb loss is present, which is very common, we strongly encourage the individual to take up our offer of transportation to the hospital. As long as xylazine continues to be present in the illicit substance supply, the issue of wounds developing in drug users will continue to be present. One solution is for individuals to have access to hospitals and healthcare. Unfortunately, as was mentioned earlier, due to the stigma around substance use and homelessness, and due to the nature of the wounds, folks we're serving have had terrible experiences when going into the hospital. Staff often ridicules, objectifies, and discriminates against those entering the hospital looking for support from wounds they developed from substance use. Our volunteers and staff have repeatedly received reports of folks with infections that need a doctor that refused to go to the hospital due to the treatment they had endured from the moment they walked in the door during previous visits. I was just reading the Q&A section a moment ago, and somebody had asked, is there something hospitals are doing for the folks that are going in and getting set up to be amputated that are just walking out beforehand because they're really not getting good treatment? And I can't answer that question, because from what I've seen, absolutely not. We are not doing anything to address that, and it really needs to be addressed. So hospital staff may benefit from training on interactions, definitely will benefit from training on interactions with those seeking treatment for substance use issues, not just wounds. Especially in Philadelphia, where these interactions are daily and must be incredibly difficult for them to deal with without training. Give me 1 second now. I'm going to share my screen. Oh. There you go. All right. And can you see my screen here?
No, we can't.
Oh, still can't see it?
Nope.
Oh, sorry about that. 1 second. Share, that's, yeah, that makes sense. All right, you can see it now?
Yes.
Great.
All right, I'm sorry, bear with me just 2 more seconds here. A little technical difficulty.
Also, folks, we know it might be a little small. Again, we'll get a copy of all of the slides to you all at the end, along with a recording of the webinar. So bear with us on the tech.
All right, can you guys see that decently?
A little, yeah, it's small.
A little bit small.
Yeah,
I could zoom in, but then you can only see like half of it.
that's okay.
All right, yeah, that'll have to do. So what I was saying earlier, let's see, I scrolled down here.
Yeah, Adam, is there a way to put it in landscape, do you think? That would make it larger?
Man, so the issue is once I put it into that, yeah, so landscape.
No
I
worries.
don't-
It's gonna be
I
no
don't-
worries. We'll just go ahead and zoom in. Thanks.
Absolutely, I don't want to take up any more time here. All right. Oh,
little better maybe. Can you guys see that?
Yeah, I can see that pretty good.
Great. All right. So on another note regarding overdoses, that was just discussing the wound care. Now I'm going to discuss the other issue that we have, which is overdoses in regards to people that have xylazine in their systems. So since discovering that much of the drug supply was being laced with xylazine, we've changed the way we reverse overdoses to ensure folks are getting oxygen to their brain while the naloxone blocks the opioid receptors. We have been training staff and volunteers to administer rescue breaths in between naloxone doses. We've always encouraged folks reversing overdoses to administer rescue breaths, though now we're taking it a step further by letting people know it's not encouraged, it's absolutely needed. We are also providing staff with face shields and beginning to provide volunteers with them as well. However, we have incredibly limited funding, so we have to purchase those ourselves. So we are asking volunteers to purchase them themselves. It can be easily bought off of Amazon or the internet. We understand people are hesitant to administer mouth to mouth with a stranger in general, especially so in the age of COVID. For those who don't know, by the way, naloxone is an easy to use opioid overdose reversal drug. Savage Sisters offers extensive naloxone and harm reduction trainings during the first stages in which we go over how to identify an overdose. Administering naloxone puts the recipient in immediate withdrawal and immediate pain. So one thing we never want to do is Narcan someone who isn't overdosing. Previous to the introduction of tranquilizer in the dope supply, an obvious symptom of an overdose was someone being unresponsive. Today, consideration must be taken regarding the chances that someone appearing unresponsive is due to the tranq effects. To confirm an overdose where tranq is involved, Chris had mentioned earlier, it's kind of obvious sometimes. You can see they're obviously breathing, they're not overdosing, but sometimes it's not so easy to tell. So to confirm, look for signs including unresponsiveness, shallow or no detectable breathing, snoring or gurgling, slow or irregular heartbeat, stiffened body, seizure-like activity, and strange behavior prior to becoming unconscious. Better yet, get an oximeter, which will tell you if someone is overdosing based on their heart rate. If you're working in the field, it's a must-have when dealing with individuals on tranquilizers suspected of overdosing. It eliminates the chance of misidentifying an overdose. Most people don't have oximeters on hand, though, so I'll go over some other options. When responding to a suspected overdose, the first step is to look for the signs listed above, address the individual verbally, ask if they are okay, tell them your name, ask them their name. If there is no response, try gently pushing their shoulder or administering a nail bed press.
Hey, Adam, I know it's a lot of info and we love, we're loving all of this. If you could just slow down the speed of the talking a little bit so folks can follow up with you and follow along, that'd be great. Thank you so much.
Absolutely. Sorry about that. All right, so I was at administer Narcan here. So when responding to a suspected overdose, the first step is to look for the signs listed above, address the individual verbally, ask if they are okay, tell them your name, ask them for their name. If there's no response, try gently pushing their shoulder or administering a nail bed press. This can be done by placing one of your fingernails on the area where the individual's fingernail meets their skin and pressing down firmly. This will cause pain, but will not actually hurt the individual. If the person still does not react, let them know you are going to Narcan them. This gives implied consent and provides an opportunity for one last verbal confirmation. Next, call 911 and put the phone on speaker somewhere you can see the time of call. This ensures that EMS will arrive and provides you with a timer. At this point, you ensure the airways are clear and administer the naloxone by placing the nasal spray device tip into a nostril and pushing the plunger. For the next 2.5 minutes, you must administer rescue breaths. Also, you must wait at least 2.5 minutes. Fight the urge to administer doses in rapid succession. It really is not helpful if you do it in less than 2.5 to 3 minutes. In the wake of tranq, the likelihood that rescue breaths are needed is incredibly high. If 2.5 minutes have gone by since the first dose and they have not begun to stir while you were doing the rescue breaths, you can stop and administer the second dose. If they begin to stir and wake up, put them into the rescue position. If they do not wake up, but color starts returning to their skin, fingertips and lips, and breathing becomes normal, they are no longer overdosing and should be put into the rescue position. That's the rescue position right there. You can see a little bit on how to do that. It's incredibly easy and eliminates the chances that they'll throw up and choke on their own throw up or hurt themselves in other ways. The rescue breath ensures their safety, essentially. That concludes the information regarding overdoses and turns to my last topic, which I do not need to share my screen for, so I will stop. Just about finished up here. So those are some issues that I had answers to. One issue that I do not have an answer to is people getting treatment that are dealing with xylazine in their system. The lack of resources for those seeking treatment that have recently used tranq is alarming. People trying to go into rehab are not getting the medicine they need to eliminate the withdrawal symptoms that they're having. So withdrawal from tranquilizer is not the same withdrawal from opioids like fentanyl or heroin. Withdrawal from tranq makes people incredibly sick, causing seizures, other dangerous side effects, and even death. Unlike opioids, which rehab facilities have meds to counteract the withdrawal of, rehab facilities do not have any medicine to counteract those effects of xylazine. Therefore, individuals who desire help and want to get sober are significantly less likely to seek treatment due to the concern of having to go through a dangerous and agonizing withdrawal, essentially cold turkey. Rehab centers have made no moves that I'm aware of to remedy this situation. Oftentimes during Savage Sisters outreach events, our staff and volunteers offer transportation and information to get into treatment to folks who we're serving. But they don't want to because they know that they will have to go get well cold. They'll have to go withdraw cold turkey. So having an answer to that moving forward would be incredible. One of the things I'm looking forward to finding more about out during this webinar. And if you would like to come, that pretty much concludes what I have to say. If you'd like to come support us on the ground, please come out to our outreach events. Every Tuesday night, 5:30 p.m., every third Saturday of the month at 10:30 a.m., all at McPherson Square. We provide a consistent place and location and time to make sure that the people we're serving have access to us. But check out savagesisters.org if you want any more information on our organization. And if you have any questions for me, put them in the chat, follow up after this, or email me directly at adam@savagesisters.org. Thanks again for having us on the platform. And thanks, Chris and Louie, for the information you shared earlier.
Awesome. Thanks so much for all that info, Adam. Yeah, folks, if you want to feel free to follow up directly, you can send them a direct chat. We'll be on for the rest of the webinar as well. We're going to go ahead and move on over to Ana Rosa, who is talking a little bit about her experience in Texas and some of the SSP responses to xylazine in the drug supply.
Hi, everyone. Thank you for having me. Let me just share. I made a small slides. I'm mostly going to just go based on that, but let me see. Share screen. Okay. Again, my name is Ana Rosa Granados. I'm a services director at the Texas Harm Reduction Alliance. I'm going to be mostly talking about how crucial it is to spread awareness in your communities about xylazine. I'm not really going to get into the medical stuff, but we do a lot of outreach, and our most important principles is to be educating our community on what new additives there are in folks' drugs as soon as possible. So let me start. Who we are a mission-based and developing, supporting, and promoting policies that help push for better laws and policies for harm reduction. Our team is composed entirely of people with lived experience that do outreach around the Austin area. We are a person-centered harm reduction services. So we go by step by what the person and the user needs. Here is our mobile clinic. We just started driving around in this beautiful clinic and distributing harm reduction supplies, wound care. We're gonna have nurses volunteering with us in order to help our community out with a lot of abscesses or loads of all kinds of infections that we've been seeing around Austin lately, especially because of xylazine or fentanyl. We've been trying to educate folks on how to use our wound care kits a lot more and keeping up to date with new additives to a lot of the drugs that folks are using. We also push a lot of policies in order here in Texas, it's really hard to do harm reduction in Texas. A lot of the stuff that we distribute is illegal, and there's a lot of stigma here as well. So educating our community and also helping them empower themselves to push policies to help with further emergencies like fentanyl or like xylazine additives. We try to tell folks like these are the realities of this state, and people here are extremely supportive and hardcore. And yeah, so that's who we are. If you have any questions or anything you want to know more about us, please put it in the chat. You could see this thing here. We have to deal with Ted Cruz when we do harm reduction policies. And yeah, it's a little rough over here. Okay, so how has toxic unknown additives like xylazine affected the drug user communities and SSPs? They create extremely dangerous situations that have not been studied or prepared for. So that's mostly one of our biggest challenges. We usually end up knowing about these things through our community, coming in, showing us what's going on, telling us stories about overdoses and deaths that they've been witnessing. And when Narcan has failed to revive certain people, that's when we really go into emergency mode and we're like, what is happening? That's how we found out about the xylazine distribution here in a lot of dope that we have been seeing on the streets. We usually tell folks, please use Narcan, but if they're suspected of any xylazine, then we tell them to really prepare to, unfortunately, like go to more extreme measures to help this person live. This results into high overdose deaths. A few months ago, we have had really intense incidents here in Austin and found out it was xylazine with fentanyl. So overdoses have been at its highest this year. So this is because of these additives and the lack of transparency or like preparedness that our state has for these situations. Those are our biggest challenges. And unfortunately, these are things that I feel like are doable, but due to a lot of stigma and a lot of different perceptions on drug users, it's been really, really hard to educate and save our community. So SSP struggle to find solution because of stigmas again, and slow research and lack of transparency to the community about potential additives. Usually the data that we get from these additives are from our clients and our peers or participants. They are the ones educating us mostly. So we try to work together as a community to see what we could do and what has helped them use drugs a little safer. How can we make this better? Just want to make sure you guys are seeing this properly.
Good to us.
Okay, thank you. I'm just seeing a different thing over here. How can we make this better? Again, this is the reality that we go through because of the results of the racist drug war. It's been really hard to really help folks out that do drugs, especially drugs that have been stigmatized and are illegal. So it's hard to really like filter or study these drugs before people purchase them because of their illegalities. I feel like the best way to do this is to legalize these certain drugs, or have things like in New York where you have a safe space to inject. These things kind of help a lot of folks not like go through an overdose. The decrease of overdose deaths in New York have skyrocketed, has lowered down. And I feel like we should be prepared to be doing this all over the country. It's extremely important. Here in Texas, testing strips are illegal. So I feel like in order to make our job better down here on the ground is to legalize these testing strips and to make them cheaper and distribute them throughout our community, no matter what. I feel like maybe having Narcan, like you have a fire hydrant anywhere in your house, is extremely important. I can't say that enough. Our community knows that enough, but I feel like a lot of non-drug users should also have Narcan wherever they're at as well. Educate on harm reduction. Harm reduction has been around for a while and it has saved thousands, millions of lives, sorry. And I feel like this, the education of it has been increasing because of politics, but I feel like we should be growing more awareness in order to help folks in our communities, especially in communities that don't know how to do like drugs properly or safer because of culture, fear, and stigma. Obviously, more funding for SSPs, especially in in states that SSPs struggle with their political climate. It's been really hard to be a harm reductionist in Texas. I was one in New York. I was one in other places, but it's been really hard to really be one here, only because of the intense stigma that we all go through, and especially in our community, our drug using community. Folks here do want to save their own lives and want to know about these really intense additives. Everyone doesn't, and if they're injecting xylazine, they would want to know about it or what their causes are, not be surprised by it, just like fentanyl. If folks really knew what they were injecting, I think they would do it differently. That is definitely something that a lot of people don't really understand if they have not been told or educated about harm reduction. But yeah, there's so many ways, and also just being a community member and spreading like love and awareness for sure, teaching people how to use Narcan, and also pushing for policies that help eliminate a lot of racist policies against like drug users. But yeah, that's the end of my presentation. Please feel free to reach out to me or ask me any questions. I'll be more than happy to reply. Thank you.
Awesome. Thank you so much. I appreciate it. Okay, we're going to keep that momentum going just so we have some times for questions at the end. And I'm going to go ahead and pass it over to Claire.
All right. Okay, please let me know if this doesn't look good.
I think there we go. We're perfect. And then if you just want to introduce yourself real quick, Claire, and talk a little bit about your work.
Yeah, so my name's Claire Zagorski. I'm a harm reductionist here in Austin as well. And I'm a harm reduction and drug policy researcher at the University of Texas at Austin's College of Pharmacy. I have a clinical background as a paramedic. I did that for about 10 years before shifting over to what I do now, and have a background in organic chemistry as well. And I try to bring that in to be useful in the harm reduction space, which I feel like it very often is. So thank you all for being here. Very excited to keep talking about this. I'm going to talk about some stuff that's slightly more niche, but hopefully helpful. I am also, like the other panelists, very happy to talk over email, answer questions when we're done. So this is something that we've kind of heard about both in part one and today from the other folks, that xylazine isn't anything especially unique. It's a continuation of what we've been seeing over several years. And as we've seen more and more splintering of the drug supply, it's accelerating even more. We're starting to see heroin being de-emphasized, and there are parts of North America where it's just difficult to find altogether and has been replaced by other things, like we kind of heard Chris talk about it earlier. So there are reasons why this is bad aside from consumer choice. So one of the big things we've talked about a lot today has been sedation. And when we've talked about our experience with anemia, and skin wounds are definitely the most, probably the most noticeable and most complained about thing. Complain sounds negative. I would complain about it too. The most remarked upon thing perhaps. So with sedation, we're seeing folks, kind of to echo Chris, we're seeing folks that are too sedate to move for hours on end. And we've talked about this in a few different ways, but there are going to be some other complications from this and things that we can do in harm reduction to help our folks stay healthier. One of the things that's especially concerning about folks being too sedated to really move for that long is the same thing that we see in folks that are unable to get out of bed or have difficulty moving or disabilities, and that we have to worry about their skin. We have to worry about blood clots, damage to nerves and muscles. If you think about how uncomfortable it can be if you like sit in an awkward position and can't move quickly, but imagine that times much more, to the point where it's starting to actually harm our tissues. I've heard lots of anecdotes, as we all have. We're anecdote-driven gang today, but plenty of anecdotes about people also nodding out in really odd positions that ended up cutting off blood flow. And I've heard at least a couple of people reported to me that folks have been diagnosed with rhabdomyolysis, like a muscle breakdown that causes toxicity to the kidneys. So we've got, unfortunately, other things to think about here as well. One of the most frustrating things about this to me is that we don't know what's going on. And this has been echoed by other people. And even within the veterinary literature, like the information known to vets and vet researchers, xylazine is used differently in animals. It's used as a very temporary sedative for procedures. It's not, and what we're seeing with humans is people being unaware that they're dosing themselves repeatedly. So we have kind of a different context there. But some things, I'm going to talk a little bit more about all of these things, but we have something else is going on here. I've gotten some information from folks recently about what we're seeing in skin wounds, like in terms of the microscopic level. So these skin wounds are a bit of a puzzle, but it's worse than I've ever seen. And I've heard a lot of people echo that as well. It's definitely not just a miss. This is something that Chris kind of pointed out earlier, that we're seeing these show up away from where people are injecting. And while a lot of them are becoming infected once they're open, that doesn't seem to be the driving issue. There's something going on before bacteria move in. So these are going to be and are disfiguring. We've heard stories about people losing their limbs from this, and dangerous. So a kind of a review of the literature about what's worked so far is not very surprising with this, but advanced and like high level wound care seems to make a big difference. I'm very hesitant to ever kind of insist that people seek medical care in this world, because I know what that means for a lot of folks. But this does seem to be a situation where kind of access to even outpatient wound care that's medically supervised is probably going to end up saving limbs and lives. And there are kind of trigger points with skin wounds that we need to stop what we're doing and go get help. And big things for me that I try to tell folks is like an especially foul odor, like kind of knocks you back and it's distinct from how it normally smells. Tissue that's turned black, which is necrosis, which we've talked about before. If the redness is spreading really rapidly. And I even show folks how to like draw a line around the edge of their redness with like a marker or a pen and then watch for it to spread. And then chunks of tissue coming off. These are all bad signs of an especially dangerous complication, in which case we need to push for urgent medical attention. And again, I know what that's asking. And here in Austin, we don't have a great resource for that. People have to go to the ER if all else fails and they are not treated well there. This is also going to be concerning down the line because anytime someone's open to the environment like this, we're going to see bacteria moving in. We're already seeing like a really concerning acceleration of endocarditis among people who inject drugs. And this is only going to kind of inflame that. It's yet another way for people to be kind of colonized and infected with bacteria that can move to other parts of our body, including the heart. So one thing that I wanted to kind of talk about that I think is going to end up being a useful bit of harm reduction is trying to address what's going on with this extended sedation. So, we've heard a few folks, so I'm not going to belabor this, talk about, check for pulse and breathing first, make sure that it's not just a deep sleep. So I think we're good on that. But, what we've been hearing is people that are out, like knocked out, not able to move, but breathing for hours and hours. I've heard like 18 hours plus, just really, really impressive amounts of time. That's really concerning. So I kind of went back and I started looking around at what was established as good practice for taking care of people that aren't able to get out of bed or aren't able to move. Because I was like, there has to be really great research on what works, and there is. So I would distill this down into a few kind of easy, achievable things that are going to make big differences. A big one is that someone who isn't moving, so someone who's not out on Xylazine, should be moved ideally every couple of hours, like every 2 hours is the clinical management guideline. So that's the ideal to aim for. And so that just means let's give whatever skin and muscle that they're laying on a break. So maybe rolling them to the opposite side. I have the recovery position up here in the corner again, just to remind everyone, this is kind of an ideal way to position people. But then let's also try to do what we can to make whatever they're laying on as comfortable as possible. So let's smooth out like wrinkles and sheets that they may be sleeping on. Especially if they still are kind of not able to get up and move yet, we can kind of really gently massage or rub the skin that they're laying on, especially if it's starting to turn a little red. Try to keep the skin clean. That helps take care of it and helps it stay intact. And if someone's, especially in bed for an especially long period of time, we can kind of bend their joints for them. You can kind of pick up a leg and rock it back and forth so that we're getting a bend at the hip and the knee. And then walking around, getting a little bit of exercise when they're able also helps. So what I'm kind of alluding to here is a concern with being immobile for long periods of time, which is a deep vein thrombosis. So these are these blood clots that can form in the veins of your lower legs. I mean, they're usually in the lower legs, in the veins that are deep or close to the bone. These can look kind of subtle. I wanted to show y'all this picture. So this leg here, this person's left leg, is the one that has a DVT in it. So you can see it's a little redder, a little more swollen, but it's nothing super obvious. But really classic signs of this are redness, swelling, and pain in whatever, in one leg or the other. So let's try to coach people. I think this would be really smart to coach people about what this could look like and things to look for. These unfortunately need to be diagnosed with medical care. But if someone does have one of these and being immobile for a really long period of time is a risk, then we do want to start considering, when do we need to go see a doctor? The big danger here is if the blood clot dislodges and starts moving and lands in either the lung or the heart or the brain. So sudden shortness of breath, they tend to catch up in the lungs. Sudden shortness of breath, chest pain, discomfort, that's 911 like right now, because we only have a couple of minutes if that's what's happened. People who are taking oral contraceptives are at especially high risk for DVTs, as well as people that smoke. And there's a couple of other things in here, but I feel like this is probably a good kind of simple harm reduction measure that we can roll out that's going to catch a potential complication of folks being out of commission and not able to move for many hours. Again, echoing some of our other panelists, this really depends on community and is a really great point to reiterate that community and network is really crucial for a lot of things, including keeping an eye on one another. Reminder that a safe supply would fix all of this, and we need to really be on the lookout for things that are going to continue like this. Xylazine is not going to be the last thing that we see in this realm. We're going to continue seeing more things. Eventually, Xylazine is going to get prohibited. It's going to happen eventually. We're seeing too much of this, and folks are going to have to move on to the next thing. So we're going to keep seeing weird contaminants in the drug supply. And this is getting scarier and scarier because the further away we get from things like heroin, which everyone knows, the more likely we are to get to a point where medical professionals don't really know what to do, because we're going to start getting into drugs that haven't been studied well in humans, things that they aren't taught about in medical school, and are going to start becoming puzzles. So something that, Louise mentioned earlier was just how unknown some of this was and how easy it was for people to miss what was going on and to kind of dismiss it and wave it away. Because, in healthcare, we're told over and over again is to stop thinking of weird things. Don't think of zebras, we think of horses, right? So we're trained to not think of unusual things, and people don't really know what's out in the drug supply unless they go out of their way to learn about it. And that's not a common thing in healthcare. So we're going to start seeing, and we already are, more and more complications from this, but also more and more misdiagnoses and people going to seek healthcare and aren't able to get the correct diagnosis because they just don't know what's going on. A review of the literature of prior care of people with known xylazine exposure were almost entirely at attempts at self-harm. And in that case, if you go read what people did, it was all just supportive. I describe it as throwing spaghetti at the wall and just seeing what worked out, because these folks would just be given drug after drug after drug, and no one really knew what to do. And that's a very dangerous situation for a large chunk of our population to be in, but it's what we're looking at next. So we're going to have to, unfortunately, keep working very hard to fix the root cause, while also trying to mobilize our folks that are out in the community, working with the people who use drugs in our community to relay information out among the networks, and to do the best that we can to find these kind of low barrier strategies for preventing some of these harms that are maybe not immediately obvious, but still really dangerous. And that's it for me. And I'm going to hush now so we can move over to Q&A.
Awesome. Thank you so much, Claire. That was so informative and really helpful for us. We only have a quick 10 minutes left, folks, so we're going to try to get it to as many questions as possible. Again, the webinar is being recorded. The transcript, the recording, and the slides of everyone will be available to everyone who registered, so no worries about that. And folks have also shared their contact information. So I'm going to go ahead and pass it over to Kim, and she's going to run the Q&A section.
Thank you so much. So we have had a vibrant Q&A. There are a lot of questions in the chat, and so hopefully we can keep up this conversation and continue to learn from each other. My dog is, you can probably hear my dog with lamb chop. So the first question that we'll take is from Sarah Mackin. Hi. Sarah's question is, SSP staff do a lot of wound care and have picked up tips for specific types of wounds that they've handled from medical providers. Are there any particular ways we should treat, wrap, or care for wounds or ulcers we suspect are due to xylazine? And are there other kinds of dressings that are preferable? And it also sounds like we have some wound care nurses and some folks who are out in the field doing this. I know many people on this panel are out in the field and are providing frontline care. So if anyone wants to weigh in on this, or any of the panelists want to weigh in on this, that would be great. So we're crowdsourcing expertise. I know someone in the chat mentioned their wound care nurse from Maryland, where this is also quite prevalent, xylazine as well. So feel free to jump in, and we can learn about sort of wound care for xylazine. Louise, also your experience in taking care of your wounds would be really interesting.
I mean, real quick, I can certainly tell you that it's been really tough, because just being involved with the medical system for people that use drugs, it doesn't matter how much privilege you have, and it doesn't matter, what the situation is. I went with Nab and his wife, and they worked really hard to get me in and treated with dignity and respect, and that's not what happened. So it's been really important for me to just keep them clean, keep them covered, and do everything I can. I've tried lots of different techniques. I've tried, and they've given me steroid cream, but I'm talking about, this is 2 years out now, and I can spot xylazine from a mile away. So and the side effects of it. And so I have not used any xylazine, and and have not been exposed to anything, but the wounds are very, very slow healing, I must say. Really, really frustrating. And then if you use drugs on top of it, really hard not to pick at, right? Really, really difficult. That's one of the big problems that I've experienced is you know, at night when I'm tired and they begin to itch and all of that. Really frustrating and really a real struggle. So it is not pleasant and really long lasting. So I encourage people, if they have good wound care doctors, to see them and to be involved, but really tough to have a system where there's anybody treating, you know, I've had trouble getting other medical stuff done because of the wounds on my arms. So, you know, because they're so you know, you can absolutely tell what they are and they're rough. And so that just exacerbates any other medical treatment. So it's been really difficult to get good medical care since this has happened.
I guess I'd have a question for the people that know more about wound care than I do. I know at least 2 or 3 people that debride their own necrotic tissue and sort of cut it away. Is this something that is recommended to do or that needs to be done? And also somebody that has a barometric in wound care that also became a user of fentanyl and xylazine mentioned barometric chambers, I suppose, which I think oxygenates the areas. I mean, or does that serve any promise in going forward? Anybody want to take that?
The one example that I've heard of that really helped, I will say, because it kind of referred to like advanced level wound care, was a wound vac, which is like a little vacuum that kind of pulls blood into them. And I imagine a lot of y'all are familiar with what I'm talking about. Yeah, hyperbaria is kind of, I think, what you're talking about. You like literally go into a chamber and it helps hyperoxygenate you. That also probably helps. I will say I know one person who had a confirmed xylazine wound that was biopsied to try to get a sense of what was going on with it. And the biopsy showed nothing unusual, which was really frustrating. It didn't show infection, but it also didn't show like a breakdown of the tissue that really pointed to like a smoking gun, like physiologically. So I feel like at this point, the answer is probably, I don't know, which is really frustrating. But I feel like a lot of it is just going to be the basic stuff. Like Sarah in the comments, like, you know, don't touch it. Just trying to keep it clean and dressed. But it's frustrating that we don't have better answers.
Claire, I had the same experience. So they did biopsy my wounds, and they did go through all of that and couldn't find anything, right? Like literally found a little bit of MRSA, but just the kind of MRSA you would see on top of anybody's skin, nothing else. And so that was really frustrating because, you know, what do you do then? I just wanted to weigh in on that.
Yeah, thanks, Louise. So that's 2 people that have, at least that I'm aware of, wow, that it got a biopsy that found nothing, which is itself an interesting finding, kind of.
Yeah, I do think we need more. I mean, I think we need more pathologic, you know, anyway, we need more pathology about this. So we really don't have any at all. So I do think if there is a suspected xylazine, you know, having that and publishing that and getting a collection of that is going to be pretty important for people to better be able to characterize it and understand these wounds. We did talk about in the first one how we don't think that they're infected, right? I mean, people might be using antibiotics if there's a super infection, but they themselves, like Louise was saying, we don't think that they're necessarily like your regular staph infection, so to speak, or, you know, they're not regular abscesses. They should not be thought of that way. They can obviously get infected because they're huge parts of your skin that are exposed. So you have to be really diligent to prevent infection on top of that. But yeah, they're not necessarily themselves infected. So other questions? There was another good question about sort of the question of if anyone's seen confirmation of xylazine and meth. And the question was, a lot of people were complaining. They were doing the methamphetamine or speed, different routes of administration, and then were falling asleep or becoming really tired, which is not really what they had intended to do. A follow-up kind of like tacking on is like, in the absence of drug checking or FTIR and mass spec, which is like mostly everywhere, how can people be identifying xylazine, you know, if by smell, by taste, by feel, by whatever means they can to protect themselves. So those last two questions are kind of like, have we found xylazine in meth and or stimulants, and what can people do to if they suspect xylazine in programs?
I could take that from the first part. In this testing we've done, methamphetamine is pretty much the only drug that comes back pure, like unadulterated. It's straight up just methamphetamine. We have not found xylazine and methamphetamine here in Philadelphia. That doesn't mean it couldn't possibly be happening elsewhere. There's been xylazine occasionally in cocaine samples, but not that I've seen in methamphetamine that we've tested.
I can honestly tell you, I mean, and unfortunately you have to try it to know that this is the side effect of it. A super dry mouth, like beyond anything that you've ever experienced. Like there's no dehydration. Like I can explain the dehydration that comes with xylazine, and I know it immediately, you know, if you know, if it's, and then just the level of tranquilizing, like when people come in and they say, gosh, this guy, you know, they use and they just go out, and there's this series of like just inability to wake up, but yet very wakeful. So you can wake them up, but you know, it's just sort of back and forth. But I would say the dehydration, and here it looks like white powder. And it almost looks exactly like cocaine. So it's really important to be careful there because it's so white, and I've seen xylazine get mixed in with cocaine and then cooked up, you know, in crack, and then overdose the person that was smoking the crack. So I have seen that. So it's really important just to note that it's white powder. Here I've read in other places that it's not white powder, but here I've seen it only as white powder.
Thank you so much, Louise. Folks, we are at time. I know there is so much information. There's been so much interest in the first part, this part as well. I want us to continue to connect with each other and have these conversations. Like we said before, our first part of the recording is already up. That link was dropped in the chat. Everyone who registered will also get the recording to this video as well. And then we'll send all of the slides and contact information that people have shared. But thanks so much for being with us. Thank you, panelists, for all your information and your expertise. And we will catch you next time.